بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اللهم صل عليه. اليوم إن شاء الله today we'll discuss some important clinical points in systemic lupus or lupus nephritis, especially in systemic lupus disease. Just I will give you some clinical pearls already and the lessons learned. I learned all this presentation from our boss, Dr. Abdelhamid, the big professor at UHN Hospital. I learned all this lesson from her and from her presentation, and I need to just to connect this message for all my colleagues everywhere, just to get benefit from this clinical experience from our boss, Dr. Abdelhamid, with our mentor and our teacher and our professor and our head of department too. Today we'll present this clinical pearl in around 5 cases presentation, already real cases presented to our clinic for our boss, Dr. Abdelhamid, and we'll discuss in details what is clinical pearl for each case and what is lesson you should learn for every case to improve your clinical practice and take more experience. توكلنا على الله ونبدأ بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. بسم الله صدق الله العظيم. توكلنا على الله ونبدأ بأول حالة أو الكيس. More is not better. Put this in your mind when you prescribe any medication for any patient in your clinic. Don't prescribe too much medication and unnecessary medication, please, especially in our country. Please concentrate to the point. Don't be happy or you feel you are boss if you are writing the prescription from A to Z. And this is the problem in our country, I know. Please concentrate is the most important, especially in chronic patient, because our patient already maybe will not compliance, maybe this non-compliance maybe because lack of education and some without economic problem. Please just try to concentrate what is your patient need and what is the most important, especially for chronic patient. Case number 1, we have 24 years female patient already presented to Dr. Abdelhamid clinic. This is a female patient who was known case of systemic lupus around 8 years ago. She's non-adherence and with multiple flares. This patient already 24 female and I think is socially isolated and live alone with non-adherence and multiple flare and no show to her clinic for 2 years. This is already this patient absent from her clinic follow-up around 2 years. No show means not taking medication. Any patient not come to your clinic means this patient already either discontinues medication or no follow-up, no more follow-up, and not taking any medication for his disease. This patient, just we know, just by surprise, this patient presented to emerge with severe flare and lupus nephritis at that time, and treated and discharged with follow-up in renal and rheumatology clinic. The patient presented after this 2 years to emerge by severe flare and lupus nephritis and treated. Received her pulse and MMF and is stabilized and discharged with follow-up renal and rheumatology clinic. Take care from this point. This is the first lesson. This is the first medication prescribed for her, 20 milligram PO BID. This is the first dose of prednisone. We can give 40 daily for 20 BID, but already the prescription done 20 BID. And MMF 1 gram BID or 1.5 grams BID. This is the second medication. Third medication, hydroxychloroquine 400 daily. And the fourth medication, ramipril 2.5 milligram per oral daily. And the fifth medication, atorvastatin 40 milligram per oral daily. And the sixth medication, folic acid 5 milligram. And the seventh, ferrous gluconate at 300 milligram daily. Pantoprazole, 8th medication, 40 milligram daily. Metoprolol 12.5 milligram BID. And vitamin B12, calcium carbonate, and vitamin D. Now your patient receive around 30 tablets per day. This is the first lesson for you. If I have received 30 tablets, I can't tolerate that. I will discontinue medication by myself. Take care from medication to prescribe you are prescribing for your patient. Don't burden your patient by multiple tablets and the economic burden and the GIT problem, and just unacceptable to give 30 tablets per day for any patient. Take care, especially this chronic patient. So what happened? What happened for your patient if any patient receives 30 tablets per day? Already your patient no show after that for follow-up clinic when the patient taking back like this, like a hemodialysis patient. Or hemodialysis taking back like this. I don't know how the patient can take this or how can compliance. Please just concentrate the most important medication, not don't prescribe unnecessary medication for your patient. Your patient presented to another hospital with acute chest pain. This patient already no show, not taking any medication, already just presented by acute chest pain. We don't know what happened for her. Maybe this severe nephrotic with DVT, pulmonary embolism, and sudden death. We don't know what happened for her, and already the patient died with no more details. This is the end of this prescription, 30 tablets per day. Your patient will be non-compliant, no show to your clinic again, and he will end by this if you don't minimize his target his medication to the point or the most important medication to his disease. This is the first lesson you should know. You should learn today. The more medication or polypharmacy and the tablet prescribed to your patient, more non-adherence. Polypharmacy for any patient, even you will see this already in our hemodialysis patient. If you will give one patient around 15 tablets per day, you know, the patient will bring by the end of the month the same bag for you. Doctor, I'm not taking this, you can return to the pharmacy. Please just concentrate the most important patient you need. Minimize number of your medicine, please. Better the enemy of God. Don't worry about lipid lowering therapy. مش لازم واحد 24 سنه ليش بتدي لها ستاتين والحاجات ديت. لو هي العينه ممكن تعمل اكسرسايز وممكن دايت والحاجات دي ممكن كنترول ذات. Don't give more just a toxic medication to her. Don't worry about reducing proteinuria with ACE and ARBs. If your patient, you know, your patient will be non-compliant, and maybe you will just gradually introduce and just to do test for your patient, he will be compliant for the onboard medication or no. If he's compliant and he came for next clinic is good, you can increase the other medication. Don't worry about reducing proteinuria with ACE and ARBs. You better don't prescribe from the first time. Forget about vitamins. Don't get vitamin folic acid, B12 and calcium, vitamin D. You can just introduce one by one, not all this. And the most important one, and better if you know your patient non-compliant, just give the most important medication for your patient. Sometimes you can prescribe 50 milligram per oral prednisone and none else. ممكن تدي لها اهم علاج عندنا في الموضوع ده كله البريدنيزون. ممكن تدي لها 50 بريدنيزون وتسيبها. وبعدين تبدا الفيتامين بي والكالسيوم والبي بي اي والحاجات دي بعدين. لو العين بدا تحس انه بقى كومبلاينس وبدا يجي لك العياده، وبعد كده ممكن تعمل تيست العين تقول له ممكن ناخده ده عشان السايد افكت كذا وده كذا. فمش لازم تبدا الليسته ب 30 تابلت ولا 20 تابلت ولا 15 ولا 10 ولا 5 من اول جلسه يعني. فانت حاول تشوف العين بتاعك الاول، ظبط العيان، ركز على التارجت ثيرابي for your disease, and after that you can introduce this other cofactor or other helpful medication to control your side effect of medication and your disease. That's the first lesson for us today. Don't give more. Minimize number of your medicine, please. Minimize number of your medicine, please, to enhance good compliance and adherence for your patient. Okay. Case number 2 came to the clinic. This is a 30 years old female patient in case of systemic lupus nephritis, treated by MMF, not improving, not getting better. Should I use rituximab? This patient referred already to the clinic from other doctor, whatever, GIM, rheumatology, other nephrology. Yes, refer for us, 30 years female, non-case systemic lupus and lupus nephritis diagnosed already. And the patient received treated by MMF and not improving, not getting better. Should I use the rituximab? He given MMF and we don't know where the prednisone here and the steroid, how much MMF, pulse steroid given, what time, duration, course. I don't know all this scenario. Just a referral like that, as is not acceptable. Should I use rituximab? This many explanation here. Our ومين اي علامه استفهام هنا، ليش انا هندي ريتوكسيماب للعينه ديت؟ هي هل البيشنت ريفراكتوري، هل هي البيشنت واخده الجود دوز او البروبر دوز and البروبر كورس and البروبر ميديكيشن and we don't know all this scenario. Just what is wrong here in our this referral? Dose and duration of steroid, we don't know. Dose and duration of steroid, we don't know. Is not getting better in 1 week, 1 month, 1 year, we don't know also. He said the patient not getting better. The patient getting better. Is just receive medication 1 week or 1 month or 1 year. Or she is taking her medicine and the patient compliance to her medicine or no, we don't know all this. You should write this patient received the steroid, pulse steroid, and continue steroid like that. Is not getting better already now. She uses medication since 1 month, 1 year, 2 years like that. Or she's taking her medicine. You should strict on this point, or to be alarming for this patient. Your patient adherence to medication or no, you should guide us for that when you refer patient. Time to recovery from proteinuria in patient with lupus nephritis by Tom et al. Already this is done 2014 by Tom et al. Time recovery from proteinuria in patient with lupus nephritis receiving standard treatment. We doing this study around 212 patients with 52 2 years here, around 52 already recovery from proteinuria, and at more 2 years already plus 22 at 5 years, around 57%, around 5 years already with improving proteinuria. Okay, just give your patient time at least 2 years, around 52%, and another 22% for this 52% at 5 years. You should wait. Don't be hurry for proteinuria. If your creatinine is stable and the serology marker or lupus marker already stable, don't be hurry to change or increase or adjust your lupus treatment, lupus nephritis medication. Okay, just wait. This study already done to give you, just wait at least at 2 years, 52%, 5 years, around 74% recovery from proteinuria from this Toronto lupus cohort study by Tom et al. And this resolution of proteinuria in lupus nephritis, hurry up and wait, is already done by our boss, Dr. Bargman. This is a picture of Dr. Bargman, our boss and the mentor at Toronto General Hospital. This is a study already done already on 200 patients as cohort study. And just what means by recovery from proteinuria is this defined as 24 iron protein less than 0.5 grams. And just this is the most important finding from this study. It takes surprise long time for most of the patient to achieve resolution from proteinuria. Just to give your patient time. Don't be hurry within 1 year or 2 years, or as you thought before is around 5 years the proteinuria improve, because this because your glomeruli need time to heal and repair. As we mentioned before, at 5 years, increase to 74% resolution of the proteinuria or recovery from proteinuria. Recovery, as we mentioned, less than 0.5 gram per day, 24 hours. This already just confirmed by Dr. Bargman in her study in around more 200 patients in the cohort study. And this already just a resolution, just time will increase the proteinuria to complete remission or partial remission with increased time, either pure membranous or mixed membranous. As we'll see here, this is the pure membranous and this mixed membranous. 100% around 15 years, like 5 years, 15 years, everything. At 15 years, around 100% from this mixed lupus, mixed membranous, and pure membranous around 79%. The recovering time resolution from the proteinuria. That's already seen by this study by our boss, Dr. Bargman. Okay. Just listen here from Dr. Bargman. Just a time. Based allow time for proteinuria to resolve rather than continue or escalating immunosuppression in attempt to hasten recovery. This is our John Bargman. This is our boss in the nephrology department and Toronto General. Our mentor and our teacher and our professor, Dr. John Bargman. Just please give time to your patient to resolve proteinuria. Don't escalate your medication, don't change your medication to aggressive medication. Just give your patient to resolve proteinuria and give time to glomeruli to be healed and to be recover from proteinuria. Okay, boss. What is the lesson here? Lupus nephritis is not minimally change disease. You will not give the medication and the proteinuria will be disappear. This is not minimally change disease. Put this in your mind. It can take months to years for proteinuria to resolve. Get comfortable with residual proteinuria. لما تلاقي proteinuria 2 grams 3 grams decreasing slowly, don't be agitated or don't change your medication. Get comfortable. To be comfortable with residual proteinuria, and please don't escalate the therapy. Don't escalate the therapy or change. Case 3, not everyone needs kidney biopsy. This is the most important case. Came to clinic or emerge, whatever, or consultation or inpatient, whatever. Case 3, not everyone needs a kidney biopsy. You receive already this patient, case 3, a 40 years female patient with remote history of lupus nephritis and lost follow-up. This patient already lost follow-up, presented to the hospital with pleuropericarditis and pancytopenia, urine, active urine sediment, 3+ red blood cells, 3+ protein, high serum creatinine, AKI already, active lupus serology. This patient active now in flare. Whatever systemic lupus with lupus nephritis, all in flare now. The patient flared now. Typical picture of patient with flare already in emerge now. Nephrology consult asking for kidney biopsy. They are just doing consultation for us to ask for kidney biopsy. What's your plan now? If you have this patient 40 years with this problem, pleuropericarditis, take care from this. This patient risk for any whatever. This is unstable patient, pancytopenia, unstable patient. But already the patient active, red blood cells, protein, with AKI, take care from AKI also, uremia, and active lupus serology. I think this patient not active to intervene with him. Nephrology consulted for kidney biopsy. Why I will give kidney biopsy? If you can diagnose this, just I need you to consider yourself in place now, away from facility to do kidney biopsy or whatever. Just this is a good case for doctor. He can not have any facility to do kidney biopsy as urgent. I think this is the best for him to deal with this patient by his clinical experience. Now, better than tertiary hospital and have facility to do urgent biopsy. This patient is lucky if he will go to doctor without facility to do kidney biopsy. At least he will start the management say, because the kidney biopsy will not add it for you anything. What the kidney biopsy will add for you by this picture. Because already you have now, because the patient is unstable now. You should start the treatment and give him pulse, give him whatever you will give as your induction and the maintenance after that. If you have facilities, I know kidney biopsy is important for grading, classification, and the prognosis and the management also. But this patient already now active patient now. What do you suspect? This patient may be class 3, class 4, maybe class 3 and the class 4 and the class 5 with together, whatever. But we already have active with proteinuria already. Active with proteinuria, maybe class 4. And they will turn to between class 4 and the class 5, maybe. I just started treatment. What is the problem? Okay. Just a consultation done for us to do kidney biopsy. And I need you to follow this to see what is happening for this patient, what is the scenario happen. If you know this patient clear like sun, this clear for you, the diagnosis from the start, what the biopsy will add for you. If the patient high risk for complication for kidney biopsy, especially if thrombocytopenia or high blood pressure or any pericardium or pleural problem, we don't know what the complication will be having after. Biopsy done already biopsy done because the patient already unlucky she came to tertiary hospital and showed active proliferative GN or lupus nephritis, active proliferative lupus nephritis. Okay, already I know this from the previous picture here. From the scenario here, this active picture of proliferative lupus nephritis already have active urine sediment. Not only protein, but all the red blood cells and high AKI and the lupus serology is active and all this with also active lupus nephritis. Biopsy showed active proliferative lupus nephritis. If anyone surprised you, I'm not surprised with it because already clinical picture with that. I have around 2 patients last week I saw with active lupus nephritis. We start already a pulse steroid with MMF induction dose, and the patient is doing perfect without any change, without any more deterioration in creatinine, and everything is stable and improve without kidney biopsy. You know, primary team internal medicine and call us to do biopsy for patient. I told them patient was pleural effusion and sometimes tachycardia, sometimes hypertension, sometimes with pancytopenia. I told them no, this patient not stable for kidney biopsy. I will, and with active urine sediment, same scenario. And already start pulse steroid and induction MMF without biopsy, and the patient doing perfect. And later we can decide after 1 month or 2 months to do kidney biopsy for classification and the prognosis and to guide us for management. But already the patient improved and they were not surprised by that. This is not surprise for us. Okay, after kidney biopsy, bleeding from biopsy, take back the complication now. You're dead already. You know your diagnosis from the history and the lab from the start. And you insisted to do kidney biopsy or rheumatology or GIM, insist to do kidney biopsy. And what happened after kidney biopsy? Bleeding from biopsy side and perirenal hematoma and the line inserted for acute hemodialysis. You know, the patient bleeded, severe blood loss, hemoglobin drop, giving blood, and the patient already in AKI. And this all this just enhance more deterioration her kidney function. And already the patient at that time hyperkalemia with volume overload, line inserted for acute dialysis as emergent dialysis. This is a complication of your kidney biopsy. And this shows his right kidney with perinephric hematoma is clear now by CT, the right kidney, and this left one, and the perinephric hematoma. With case 3, not everyone need kidney biopsy. Put this in your mind. In lupus nephritis with lupus flare, not everyone need kidney biopsy, need a kidney biopsy. Line sepsis after that. This patient already inserted line sepsis because emergency may be inserted at night, maybe inserted by confused on call or tired on call already, and maybe a septic problem, septic technique problem, whatever, under stress, all this, and the line in sepsis is a complication of our line insertion, and the bacteremia staph aureus from our patient with all iatrogenic bleeding, iatrogenic line sepsis, iatrogenic staph aureus. Now where it will go? She already seeds to the perirenal hematoma leading to abscess. Staph aureus seeds the perirenal hematoma and leading to abscess, and that patient ended by septic shock, ICU, and death. This is your decision. If you are not wise and you are not insist for your opinion or you don't have experience, you will listen just for rheumatology or internal medicine, do kidney biopsy, do kidney biopsy. Don't be like that. You should have clinical and lab and everything. If it's okay, just stabilize your patient, start your management, stabilize your CBC, stabilize your blood pressure, stabilize your patient, and after that you can decide to do biopsy or no. Just keep your patient ABC and then start to invasive maneuver. Just think 1, 2, 3 to 100 to do biopsy or no before your decision, because sometimes the patient already on her or his management for lupus nephritis or lupus flare by rheumatology, already the patient on. What you will add after this medication, you don't add anything. Just to keep your patient stable, and after that you can decide. You can do kidney biopsy after 1 month or 2 months. Don't be hurry. If no indication, if the diagnosis clear like our patient, this is the end of your patient, ended now by septic shock, ICU, and death. I hope this message, third lesson, reach clear for each one. Unnecessary or high-risk renal biopsy. Patient present with explosive lupus. The patient already came by lupus flare and high creatinine, AKI, active urine sediment, high blood, and hyperprotein in urine. Why do you need the kidney biopsy now? You know what the diagnosis is. Already you know the diagnosis. What is the benefit of kidney biopsy? It's probably the high-risk biopsy too. High blood pressure, high creat, low platelet, it's lupus and it's bad. Take care from that point. Unnecessary or high-risk renal biopsy. Patient present with explosive lupus nephritis, high creatinine, active urine sediment, high red blood cells in the urine, and high protein in urine, +3. Why do you need kidney biopsy now? Just ask your question. What is the benefit of kidney biopsy? Now, you know what diagnosis is. Already you know diagnosis I mentioned for you. It's probably a high-risk kidney biopsy to secondary. Maybe the patient, I'm sure the patient hypertension is high and with AKI and low platelet, it's lupus and it's bad. Don't forget this message, please. This is the first lesson. Unnecessary or high risk renal biopsy, or patient present with severe extra-renal lupus that mandate extensive immunosuppressive therapy in a way like this patient already just came pleuropericarditis. Please, your patient present with extra-renal lupus that mandates extensive immunosuppressive therapy anyway. Why do a kidney biopsy at that point? What's your thinking? Why you will do kidney biopsy at that point? If your patient already came by extra-renal now, this pleuropericarditis with just finding pleural effusion, and maybe a patient will go to ERDS, you will send this patient to kidney biopsy. The patient unstable, your patient unstable, you will send him to kidney biopsy, and maybe you'll delay your management. Better to start your management, stabilize your patient first, and after that, okay, just proceed for kidney biopsy later, 1 month. 2 months, not problem, because you already start your management. What is the urgency now for kidney biopsy? Okay, this lupus pneumonitis and the hemorrhage already, we need to start aggressive management for this patient, pulse steroid and MMF, and we'll see. When should a lupus patient have a kidney biopsy? A kidney biopsy is probably already more informative around the decision to decrease immunosuppressive therapy. When I know when I can do the kidney biopsy for follow up my patient just to decrease the immunotherapy, ongoing proteinuria in face of otherwise improving lupus, ongoing proteinuria in face of otherwise improving lupus, rising creatinine in face of otherwise improving lupus. This is a kidney biopsy is probably more informative around the decision to decrease immunotherapy. لو انت عايز تكلم ثيرابي بس في نفس الوقت انت عندك بروتينيوريا شغاله بس عندك اللوبس امبروفد، لو عندك رايزنج في الكرياتينين بات اللوبس امبروفد، في الحالات ديت قبل ما تقلل الاميونوثيرابي بالله عليك تروح تعمل كدني بيبسي الاول تشوف الدنيا فيها ايه. وضحت الرساله؟ اتمنى تكون واضحه. يبقى انا اعمل كدني بايوبسي هتكون هتديك معلومات اكتر مور انفورماتيف عشان لما تيجي تقلل الاميونوسبريشن، خاصه لو انت عندك بروتينيوريا شغاله بس اللوبس امبروفد او الكرياتينين عمال يزيد او عالي بس اللوبس امبروفد، انت عايز تقلل لازم تعمل كدني بايوبسي قبل ما تقلل الاميونوسبريشن. وصلت الرساله؟ When should a lupus patient have a kidney biopsy? When should a lupus patient have a kidney biopsy? To rule out other cause of renal or renal involvement. To rule other causes or renal involvement, like TMA, thrombotic microangiopathy, if patient was positive APLA, antiphospholipid antibodies, antiphospholipid syndrome antibodies. Now, when should lupus patient have a kidney biopsy to rule out other cause of renal involvement, like thrombotic microangiopathy if patient positive APLA, antiphospholipid syndrome antibodies. Also, biopsy often too high risk for this patient. Take care of this, your mind. Other suspected medication or comorbid disease like diabetes. لو معايا diabetes مع العيان ده انت خايف يكون diabetic nephropathy ولا other, you should do kidney biopsy for this patient. Okay, other causes or renal involvement, don't forget TMA, especially in patient who is positive APLA, the high risk biopsy, take care from this patient, or other suspected medication because that renal problem or comorbid disease like diabetes. What's the lesson here? A kidney biopsy is not necessary in face of an obvious diagnosis. لو diagnosis واضح وظاهر معاك من الكلينيكال هيستوري واللاب والسيرولوجي والكلام ده كله, not necessary at urgent state or at presentation. A high risk kidney biopsy is really not necessary in face of obvious diagnosis. لو عندك high risk kidney biopsy عين بليتلت واقعه والبلاد بريشر عالي واكيوت kidney injury, why you are hurried to do kidney biopsy? This is the second lesson. Biopsy may be more informative around the decision to decrease rather than increase immunosuppression. دي البيوبسي. انا عايز اقلل منه سبريشن بس قلقان لان لسه البروتينيه شغاله معايا والكرياتين لسه معلق معايا، فانا عايز اقلل منه سبريشن بس خايف نقلل يحصل لي ريلابس او فلير، فتعمل كدني بيوبسي في الحالات دي قبل ما تقلل اميونوثيرابي للعيان بتاعها، قبل ما تعمل تبريد. Case I think is this case number who this case 3 I think is this case 4. This case 4 one of these things is not like other. Okay, one of these things is not like other. This is a fourth case. This is a 24 years female with history of therapeutic abortion after 8 weeks gestation, more than 20 years. عندها therapeutic abortion after 8 weeks from her pregnancy. I think it's more than 20 years. I think this patient 40 years. I put it by mistake. This patient around 40 years. Then after she observed, after the abortion, she observed nodules and patchy alopecia in her scalp, and swelling and polyarthralgia in her hands and knee with difficult walking and weight loss. This patient, 40 years, female, not 25, 40 years, with a history of therapeutic abortion after 8 weeks from gestation and more than 20 years now. She's married, I think, 18 years. After she observed after this abortion, she observed nodules and patchy alopecia in her scalp and swelling, polyarthralgia in her hands and knee with difficult walking and weight loss. The patient of 40 years. And her lab, hemoglobin 9.3, MCV 82, white blood cells 3.4, and lymph 1.6, neutrophil 1.4, and the platelet 45. We have thrombocytopenia, we have anemia, we had leukopenia, pancytopenia picture. And urine active for red blood cells plus 3 and albumin around 1 gram. And the granular cast with no cellular cast, okay? No red blood cell cast, no white blood cell cast. And the creatinine is 0.4, I think is normal. And ANA is positive and double strand. And double strand also is positive. With C3, C4 already is low, consumed. Now this patient 40 years with abortion, therapeutic abortion already done more than 20 years. And she after that discovered alopecia in her scalp and polyarthralgia and difficult in walking and weight loss. This is the history of your patient, and the lab came by pancytopenia, active urine sediment with both red blood cells and albumin is positive with no just only granular cast, no red blood cell cast or white blood cell cast. Okay, creatinine is still normal, ANA is positive, and the double strand already positive, C3, C4 already consumed. Okay. And this hair biopsy already shown this. Just if you will see just thickening of capillary glomerular basement membrane, this is already thickened already in this biopsy. It looks like normal, but already with thickness. If you look for the thickness, you will see this thickness of hair glomerular basement membrane with more cellular proliferation already here. The patient started in prednisone 1 milligram per kg. MMF 1.5 BID. Just MMF to start for like this patient, you can start by 1 gram and you will see a response, and you can increase to 1.5 if your patient tolerates. Or gradual 500 BID, then 1 gram BID, and then 1.5 gram BID. These are different protocol. I do like, but the recommended dose 1.5 gram per day, 3 gram per day. And the prednisone 1 milligram per kg, hydroxychloroquine 400 daily. And the patient already discharged, stabilized on that medication and discharged. And the post-discharge, she presented again by severe urticaria rash and drug reaction. And we think this is related to MMF. And already the MMF changed to azathioprine. MMF, we changed that medication to azathioprine. Complement, hemoglobin, albumin, all normalized. And the slow prednisone tapering, 24-hour AM protein, more than 400 milligrams per day. I think this will take time, don't worry. We are really happy by this scenario. Everything is stabilized for her. We are start tapering at the protein. I think a protein less than around 500 milligram. Okay, with 500 milligram, reach 500 milligram per day, 0.5 gram. We are really happy for that patient, for this patient, This is the classic proliferative lupus nephritis with hypocomplementemia, subnephrotic proteinuria, good response to immunotherapy with normalization of serology and improvement in other parameters. We are really happy for this improvement and good response to immunotherapy, prednisone and MMF. Oh, but then within less than 1 month or 1 month abrupt onset of anasarca, drop in serum albumin, 24 hours, urine protein repeated 12 gram, venous Doppler is normal for renals and DVT or lower limb veins, already all this negative. Any patient with severe proteinuria like that, you should do renal Doppler for renal veins to rule out renal vein thrombosis and the bilateral lower limb DVT. Because this patient, we have many scenarios for this patient with heavy proteinuria and already died from pulmonary embolism. This patient should receive anticoagulation, whatever. Now, abrupt onset anasarca, drop in serum albumin, hypoalbuminemia, generalized edema, nephrotic range, proteinuria, and venous Doppler is normal, serology still normal. Okay, biopsy showed membranous. I told you before, in the first one, I saw sickness here with just proliferation. But the thickness of the global base membrane is clear, but with mild cellular, if you need see cellular, you just see at least 4 blue nucleus arranged together in one row. We see this proliferative gene already. But this patient already repeated biopsy already done, showed pure lupus membranous nephropathy. And now we show thickness increase and clear now. And also biluminar fluorescence, and also here, same picture here I saw before, and this membranous, and this is subepithelial deposit already. If you will see, you'll see podocyte, and under the podocyte is a black dots subepithelial deposit. And this I magnify for you. This is a glomerular plasma membrane already second. This with silver stain already. This is the thickness in the glomerular capillaries. The glomerular base membrane already second. This is a typical picture of silver stain for membranous nephropathy. And this magnify more to our colleagues to know this. And you will show here this podocyte with subepithelial spike deposition already here. This clear now, typical picture for membranous nephropathy. And this I magnify this for our colleagues also to see this subepithelial deposit here. Bioelectron density deposit, mostly within stage 1 and 2, and extensive food podocyte processes already extensive food process obliteration all here, and with this subepithelial deposit. Outcome: prednisone increased and cyclosporin 50 mg per oral started. Now prednisone dose increased and the cyclosporin 50 mg per oral PID started. Cyclosporin titrate up to 100 mg BOPID, and the gradual already decline in proteinuria over 1 year. Current 24-hour urine protein 0.5 mg per day. Serum albumin is normal now. This is the outcome of our patient. She already shown the first biopsy, focal proliferative, and then repeated biopsy. The patient worsened came by anasarca and the nephrotic range of proteinuria around 12 gram. Repeated biopsy already showed this lupus nephritis, class 5, membranous. Started in prednisone increased and cyclosporin added, and increased dose from 50 BID to 100 BID. And with gradual decline in proteinuria over 1 year, not 1 month, not 1 week, over 1 year. Don't be hurried to improve proteinuria as we mentioned before. And the current 24-hour urine protein 0.5 gram per day and serum albumin normal. Okay. This membranous lupus is different disease, not every patient like Lazar. She presented with severe membranous lupus in face of intense immunosuppression and normalization of serology. Up to half of the patient with membranous variant may have normal level of anti-double strand DNA and the complement. Many patients present with isolated proteinuria in the absence of extra renal manifestations, so always check ANA. This long-term outcome of Chinese patient with membranous lupus nephropathy, this already done by San et al. And his group already. This long-term outcome of Chinese patient with membranous lupus nephropathy. Just here he show at 5-year survival and 10-year survival. Already here, this is a cumulative without remission, this cumulation without remission, this follow-up. We show here just 5 years of survival around 96% outcome, and the 10-year renal survival around 93% at 5 years. Renal survival at 5 years 96%, and at 10 years 93%. A third of those biopsies transition to proliferative nephritis, predictor of renal failure. In the kidney biopsy, when you saw tubular interstitial IFTA, this is a tubular atrophy and interstitial atrophy, or nephritis or fibrosis, interstitial fibrosis, tubular atrophy. This is the predictor of renal failure, and this will worsen prognosis if you have the high IFTA and urine protein more than 3.5 grams. This is also predictor of renal failure. Not going into remission, this is a predictor of renal failure. Transition to proliferative lesion, this is also a predictor of renal failure. Take care from this. This Sun et al. Already done 2008, and he discovers this around 5-year renal survival around 96%, 10-year renal survival around 93%. Let's conclude from this Sun et al. That the patient with renal survival higher in membranous lupus nephritis and severe IFTA and histological transformation, like the patient will be transferred to proliferative form. This is a high risk for end-stage renal disease and needed close follow-up and rebiopsy only if refractory to treatment. If you are given treatment and no response for proteinuria and creatinine and serology, or repeated relapse during the follow-up. Okay, just this remission during the follow-up, as we mentioned, it's around 5 years a remission like that, and around 10 years a remission around survival around 93%. This around 68% remission at 1 year. At 1 year, 68% remission at 1 year, 12 months here, and this 2 years around 85% remission. This just with the time at 1 year and the 2 years around 68 in remission at 1 year and 85 in remission at 2 years. This is a study, her name long-term outcome of Chinese patient with membranous lupus nephropathy. It's already done by Sun et al. 2008, and this discovered already here at 1 year remission for this proteinuria and membranous nephropathy with the treatment around 68%, and 2 years 85%. This is just a lesson or message for us. Don't be hurry for resolution of proteinuria in patient with lupus nephritis, especially class 5. Treatment-directed immunosuppression, very little evidence. 1 randomized control studies, 24 patients over 12 months. 3 therapies already: alternative day prednisone or alternative day prednisone and IV cyclophosphamide, and other alternative day prednisone and cyclosporin. Did I mention that I was alternate day prednisone? That I need you to know many therapies can be used. Alternate days prednisone alone or with cyclophosphamide or cyclosporin. And we show here the lupus nephritis. This study consists with those idiopathic nephrotic syndrome. Cyclophosphamide lead to more remission than cyclophosphamide. As we see here, IV cyclophosphamide as regarded relapse is low, and as regarded remission is better also. The best one in remission is cyclophosphamide, better than cyclosporin and the prednisone. And as regarded relapse, the cyclophosphamide lose the relapse, but just you should discuss fertility issue and the infertility issue for our recipient or our patient for this cyclophosphamide. And already another study, systematic review and meta-analysis of immunosuppression therapy, clinical trials in membranous lupus nephritis, around 430 patients, 35 patient paper were found, 24 studies were adequate for meta-analysis and bought into 34 treatment group. Even of 30-40 were steroid only. Other groups received with the steroid. You have 7 groups only received steroid, and the other groups from 34 received azathioprine, MMF, chlorambucil, cyclophosphamide, cyclosporin, okay, or C9, cyclosporin, tacrolimus. We found already this complete or partial remission is better with steroid and other groups, whatever other immunosuppression. As we mentioned before, either as a MMF, chlorambucil, cyclophosphamide, cyclosporin. I think a complete or partial remission better with this group, receive the steroid and other immunosuppression better than the steroid only. And this also, can we get away with lower dose steroid? You know, some patient, we have this some patient with flare of diabetes or type 1 diabetes, other patient with osteoporosis, patient with non-life-threatening disease were treated with rituximab plus pulse steroid only on day 1 and day 15, and you can do maintenance by MMF without no steroid. Okay, the patient with non-life-threatening disease, you can give him just only rituximab and the pulse steroid in day 1 and day 15. With maintenance, just MMF with no steroid. So this was not a steroid-free regimen, just no oral steroid. Inspired by recent experience with the steroid-free protocol for renal transplant. This already done from prospective observational single center cohort study to evaluate the effectiveness of treatment of lupus nephritis with rituximab and MMF, but no oral steroid. This rituximab and the pulse steroid followed by MMF, the protocol here, just to give 1 gram IV on day 1 and 15. The protocol for patient high risk for steroid, for maintenance steroid, just rituximab 1 gram IV, day 1, day 15, methylprednisolone 500, day 1 and day 15 with rituximab, and MMF 500 BID titrate up to 1.5 gram BID. Okay, this is a protocol for steroid-free regime. Don't forget this protocol. And this rituximab and the pulse steroid followed by MMF. We have, you know, now the most important class here. There was over representation of this membranous class 5 nephritis compared to other cohort studies. This membranous the most famous class here in this study, and also lupus nephritis. Rituximab and the pulse steroid followed by MMF by week 52 weeks, 52%, around 52% were complete or partial remission. By 52 weeks, 52%, 52 weeks, 52% complete or partial remission for our proteinuria. And here, rituximab and pulse steroid followed by MMF. As a time of complete remission was independent of histological class. Class 3 always lags behind my impression. Just not as take long time, especially class 3 is active class already in lupus nephritis to achieve complete remission. This will take time to achieve remission. What is the lesson here? The best treatment for membranous is not established till now. The best treatment for membranous is not established. Most authorities recommend directed immunosuppression only for those with nephrotic range proteinuria or declining kidney function. It appears to have a different pathogenesis from proliferative lupus nephritis. It appears to have different pathogenesis from proliferative lupus nephritis. Take care from this. Now, the best treatment for membranous is not established. Don't forget that. Most authorities recommend directed immunosuppression only for those with nephrotic range proteinuria or declining renal function. We have nephrotic range, and we have, maybe I will give one presentation for this membranous in lupus nephropathy, how to manage and how to follow protocol for this patient with nephrotic range proteinuria and with AKI. And don't forget, it appears to have different pathogenesis from proliferative lupus nephritis. As I mentioned, this class 3 already will take longer time to complete remission or partial remission. I think this is the last case, the previous case 4, and now case 5. Patient lie. بيشنت عمال كذب عليك او البيشنت بيكذب عليك. هتلاحظوا ازاي في العياده عندك، هتلاحظ البيشنت اللي بيكذب عليك. Patient lie, 25 years old male patient at age 22. He went to another hospital with adenopathy and had the history of adenopathy and the constitutional symptoms, and with 4 gram proteinuria and the seizure at time. Lupus serology is positive, and the cardiomyopathy and the hemophagocytosis on bone marrow. Kidney biopsy class 4-5 lupus nephritis. This patient came for you as a referral also. At age 22, diagnosed with this adenopathy and 4 gram proteinuria, seizure, lupus serology positive, cardiomyopathy, hemophagocytosis on bone marrow, and kidney biopsy shown class 4 and class 5 lupus nephritis. Treated with pulse steroid, MMF. MMF should be 1.5 gram BID. don't know if he received direct treatment for the hemophagocytosis or no. Gradual improvement, slow tab steroid, normalizing kidney function, but continue proteinuria. The patient normalized now kidney function, and battery proteinuria is continued. He received now steroid and pulse steroid and MMF. Age 24, 25, flare of lupus again, proteinuria, serum albumin 17 gram, dropping, and 1.7 gram per day, 24-hour protein. Restarted again 50 milligram prednisone daily, MMF increased to 1.5 gram from 1 gram, and followed for several months, no improvement. No improvement, no improvement. Okay, 24, 25, young age. Flare of lupus, proteinuria, albumin 17 gram, and 24-hour protein 1.7 gram per day. Restarted in 50 milligram prednisone daily, MMF increased to 1.5 gram BID. Followed up for several months, no improvement. Patient did not look cushionic. If you know your patient compliance in your clinic, you will find your face like cushionic, moon face. This patient not looks like that. But swear. يزعم عليه يقسم لك والله بناخذ العلاج اقسم بالله but swear that he was taking his medication. If he swear, any patient swear for you, just you should suspect is 100% is lying for you, or 99% is lying for you. Lie for you, was taking the medication, that he's swearing for you that he was taking the medication. Development of anasarca start to increase, chest pain, increased throbbing, acute non-STEMI, and patient admitted to CCU. The attending physician came to see him. CCU doctor, cardiology doctor, came to see the patient, and the patient said for him, what the patient said for the cardiology doctor. Listen now. What did the patient say to the CCU doctor? I have never taken my lupus medicine, never. I have never taken my lupus medicine, never. يعني انا ولا شفتها ولا نعرف اسال ادويه اللوبس دي، يعني هو عمال ياخد الادويه ما بيصرفها او ما بياخدها بيرميها، الله اعلم. This resistance lupus nephritis for increasing creatinine or proteinuria, repeat renal biopsy may help to differentiate from superimposed scarring. This ungraded, this is as KDIGO recommendation. If you have patients like that, increasing creatinine and proteinuria, a repeat kidney biopsy may help to distinguish or differentiate from superimposed scarring. Maybe a patient shifted from class to class, we don't know. If it's still active disease, consider alternative agent. This ungraded also, this both ungraded by KDIGO. If it's still active disease, consider alternative agent, يعني another immunosuppression, consider IVIG, rituximab, or calcineurin inhibitor. I think this to 2012. I will review that 2021, what is the update for that. And KIDUKI guidelines in 2012 already. One of the major cause of non-response is not addressed in 2012 guidelines, KIDUKI guidelines, non-adherence to therapy. This is not addressed and already put it. I will show you now in 2021 KIDUKI guidelines. Non-adherence to therapy should be the first line for patients with refractory or resistance lupus nephritis, membranous lupus, especially membranous or proteinuria. Think of this if serology not improving and hemoglobin not increased. You will think in non-adherence if serology not improving or hemoglobin, not CBC in general, not improving. Think of this if a patient doesn't look cushionic. I told you, your patient not like moon face. Think of this if a patient cannot immediately tell you how many prednisone tablets they take every day. If you will ask him how many tablet prednisone he will take per day, he will be confused and irritable. He told you, I wouldn't know. You'll be sure your patient not adherence to be wise in your clinic. Just if your serology, your hemoglobin not improving, this means your patient non-adherence. If the patient doesn't look cushionic, it means non-adherence. If the patient ask him what amount of your tablet you are taking per day and he not know that, he means your patient non-adherence to therapy. This is the first differential diagnosis should discover. Here in KIDUKI, if you nag long enough, receive the guidelines. If you nag long enough, receive the guidelines. The first line here, in patient with refractory or unsatisfactory response to treatment, especially this patient with lupus nephritis class 5, and verify adherence to treatment. This is what we need. It's already confirmed here by Kidigo 2021. Verify adherence to the patient, and the other you can read already. How to increase the adherence? I don't know. If you ask a doctor how to increase the adherence, we don't know. Many patients are not told that the lupus is life-threatening disease. You should inform your patient by the risk and of your disease and the complication will be happen if you are not taking his name systemic lupus disease. He can catch any body's we catch any system or any organs in your body, and will damage you, and will end by disaster end or bad end for your patient, and end disaster for you. And you can discuss every complication of any organs or any system in your body, and you put your patient to be clear and let him ask him to read more in his disease, and try to do your best with your patient to let him understand what is his disease and what is his complication and how can control this disease and what is the problem if you're not taking his medication like that. You need good education. I tell them that it's like being diagnosed with cancer. Some doctors like that tell them this aggressive disease, if you will not treat him, he will damage you or kill you. They are going to go through a bad phase with typical changes, but will come out the other end in better shape. يعني من الخلاصه كده، يعني انت لو التزمت على العلاج زي مريض السكر بالظبط، like diabetes. If you will comply to your medication and your education and your doctors and the nurse, you will do better. If you will neglect the medication and non-adherence, you will end by all complication of diabetes. The same with lupus nephritis. You should take some time with your patient to learn him and to give him clear message about his disease and his complication and how to avoid that complication. What is the lesson here? Adherence to therapy is much bigger problem in lupus than we know. What is the lesson? Adherence to therapy is much bigger problem in lupus than we know. Keep the number of medication is to minimum. Don't forget this. Adherence, be sure your patient adherence. I learned you before. And keep number of medication minimum, please. Don't write big list, please. مش لاقي ياكل اصلا، تروح تديله لسته، حاول تديله العلاج المهم. Contact the patient pharmacist. ممكن تروح تسال البيشنت فارماسي لو انت عندك system closed system or closed loop. You can check your patient about the prescription and the refills, because sometimes you're giving prescription for 4 months, for 6 months in the computer system hospital. Please just try to track your patient, or just keep one nurse to track the medication for your critical patient. Contact the patient pharmacist about the prescription and the refill. Don't take it personally, but your patient may lie to you. ممكن العيان يقول لك انا باخد واحد اقسم بالله وعلي الطلاق وعلي مش عارف ايه. لا، انت ما خليك، حاول تاخد بالك من الحته ديت. ممكن المريض لو حسيت انه بيحلف كتير كده تعرف انه ما بياخدش العلاج. Summary of lessons learned. Most patients with lupus are young. Most البيشنت هتلاقيهم young. ما هوش مدرك اصلا، ما عندوش education كويس. عيان ممكن يكون ما خدش فول education للديزيز والكومبليكيشن والمانجمنت واهميه العلاج اللي بياخده اصلا. Most patients with lupus are young and not used to taking pills. Keep it simple, please, as you can. 1 or 2 or 3 maximum. Don't increase more than this. And start by the most important, and then you can gradually increase one by one each clinic visit. It takes longer for resolution of hematuria and proteinuria than you think. ما تقعدش تقول البروتينوريا بعد شهر، تيجي تعيد العيان بعد شهر ولا بعد شهرين تلاقي نفسها تروح هذا كده ما فيش ريسبونس. لا، نزود نقلل نخش بدرجه ثانيه. ما تستعجلش، معاك لمده 2 5 سنين وبعدين تكرر، او على الاقل سنه يعني. It takes longer for resolution of hematuria and proteinuria than you think. Lesson 3, kidney biopsy is not always necessary at presentation of or flare of lupus nephritis, especially if it is high risk. Kidney biopsy is not always necessary at presentation or flare of lupus nephritis, especially if it is a high-risk patient. Patient came clear with proliferative AKI, pancytopenia, and all serology is positive or active, and the patient hypertensive, pancytopenia, high creatinine, and already active urine sediment, protein, and why you are hurry for biopsy. Maybe some pericarditis and pleural effusion or pneumonitis or ARDS. Don't be hurry for biopsy. Start your management, induction, and then maintenance, and after that stabilize your patient. After 1, 2, 3, 4 months, you can do the biopsy. Don't be hurry, okay? Membranous lupus nephritis appears to be a different kind of disease compared to proliferative lupus nephritis. Membranous is better survival, renal and patient outcome, better as we said before, better than this proliferative class 3, will take longer time to recover. But membranous lupus nephritis appears to be a different kind of disease compared to proliferative lupus nephritis, because I told you before, membranous better survival, better renal outcome than proliferative, as regard the recovery for proteinuria, membranous better than sometimes better than proliferative, as we mentioned before. Non-adherence to therapy is probably much more common than we know. Non-adherence to therapy, more than what you expect in your mind. Just concentrate in your patient, look for your patient, and be sure your patient adherence will know. You can ask him what is the number of tablets you are taking daily. Maybe it will take time to remember, or you take time to think. You see, this 99% he is not taking the medication. If he's not looks like cushionic voice, if it's your serology and the hemoglobin not increased, this means your patient not taking his pills. Even if your patient swear or عمال يحلف كتير في العياده، تعرف ان المريض ده ممكن 99% ما بياخدش العلاج بتاعه لو باقي البارامتر موجوده. Non-adherence to therapy is probably much more common than you know. واخيرا اتمنى يا رب تكونوا استفدتوا شيء. I hope everyone get benefit today and listens to improve his experience in his clinic with his patient. ونلقاكم الله في فيديو، ونلقاكم قريبا ان شاء الله باذن الله في فيديو قريب باذن الله. نكمل موضوعات حلقات الهيمودياليسيس، لان فاضل عندنا الاكسس بروبلم في الهيمودياليسيس يونت because I have long round in hemodialysis. I am not finished, just I finished some medical problem and I will continue other problem next video in الهيمودياليسيس. ان شاء الله تكون الفيديوهات محصوره على الجروبين زي ما قلت لكم، على اليوتيوب عبد الحميد ابو غانم نفرو، وعلى الجروب على الفيسبوك عبد الحميد تيوب 2 كلينيكال نفرولوجي. ما حضر ما هشتت الناس ولا هعمل كونفيوجن وهوزع الفيديوهات على جروبات كتير بعد كده، فالفيديوهات كلها هتكون محصوره على المكانين دول، وبس فقط للتركيز على المكانين دول. ولما تحب تعوز معلومه ما تقعدش تدور في كذا جروب، يبقى هم الاثنين جروب دول اللي عليهم الاب تو ديت والحاجات الريسنت، واي كلينيكال اكسبيرينس هحطها على الجروبات ديت. وانا اسالكم الدعاء بالتوفيق والسداد والصحه والعافيه والبركه في المال والاهل والاولاد. ولا تنسونا من صالح دعاءكم، واليوم الجمعه لا تنسوا الصلاه والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونترككم في رعايه الله وحفظه، والسلام عليكم ورحمه الله وبركاته.